Hey, good afternoon, everyone. Welcome to Ethics for Lunch. My name is Mark Hughes. I co-chair the Hospital Ethics Committee, and many of you are familiar with Ethics for Lunch, but those that are new, it is an opportunity for both the Ethics Committee and the Berman Institute of Bioethics to bring in a topic of clinical ethics interest to the community and learn something from panelists that might have expertise in that topic, as well as hear from the audience about the issue if they have questions or might have their own areas of expertise that they can also speak to the issue. So I'll run through some CME slides just first to get situated. To let you know that this is an approved activity through and designated for 1.25 hours. So we'll go to aim for 1:15 for this session. We have a policy on presenter disclosures. So I think for today, we don't have any conflicts of interest, and I don't anticipate we'll use any off-label use of medications. We'll identify that if that does become the case. This is for everybody in the Hopkins community. So all members of the healthcare team, as well as community members, we invite everyone to come, and we record it so that's available on the Berman website afterwards. And these are our learning objectives. So, a multidisciplinary approach to thinking about medical education broadly, but specifically with regard to ethics education, how does that impact on patient care? How do we translate these ideas of research or clinical practice into taking care of patients, and then hopefully fostering better communication with all stakeholders. So that's what the overall objectives are. We'll have some specific objectives for today. And as I said, no one for today has any conflicts of interest to report. So for today, we're going to be talking about issues that involve end-of-life care in neurology, specifically with regard to determination of death by neurologic criteria. So there might be times where there might be mistrust or cultural underpinnings for how a family is approaching the healthcare system, and where there may be opposition to the declaration of death by neurologic criteria. We'll explore these cultural and religious theological beliefs, especially with regard to definitions of death, of the old cardiopulmonary criteria, now the more recent death by neurologic criteria. Discuss the moral and legal underpinnings for those things, and then also once there has been a determination of death by neurologic criteria, whether there's an opportunity for organ donation, and having to approach families about that. All right, and I think we always try to de-identify patients or have an amalgam when we present a case. So it's not actually a real patient, but if there were any actual patient identifiers disclosed by myself or any of the panelists, that there's an expectation that you'll keep that information confidential. And for those that are interested in CME credits, this is the number that you would use on your cell phone. And do we have the actual code there? Is 51356. That so I think so the 844-10555 is the new one. Okay, so the previous slide for future reference. And 51356, and then that gets into the CME system and make that available to you for the future. All right, I think that is all the CME stuff, and if there's more information you need, you can go to the CME website. All right, so why don't I have our panelists introduce themselves? We'll just go down the road. Say who you are, what you do.
Hey, my name is Rohan Mathur. I'm a neurointensivist and neurocritical care physician here at Johns Hopkins. I take care of patients here who have this particular condition, and so I'm excited to be here to talk to
My name is James Mattis. I am a chaplain fellow here at Johns Hopkins Hospital. And as part of that role, I serve in the neurocritical care unit. And I also have another role as a family advocate in the hospital. So in that role, I work with a lot of these end-of-life situations, particularly with the NCCU. Thank you.
I'm Amy Cordero. I am the dedicated social worker at NCCU.
I'm actually a nurse in the surgical ICU and also a nursing representative on the office.
Great, so we'll hear from the panelists. First, I'll present a case and then get their reactions to the case. I've already told you about our own objectives. So this is John Doe, an unidentified male who was discovered unconscious on the street with obvious head trauma, and apparently had been from a fall. All the details were lacking. EMTs were called and responded. Bystander had found him and we called 911. He was in cardiac arrest when EMTs arrived. They initiated CPR and were able to establish return of spontaneous circulation. As part of the resuscitation measures, he was intubated. He was stabilized in the emergency department and then transferred to the neurocritical care unit and was hypotensive, requiring vasopressors, and was also on mechanical ventilation. From the onset, it was clear that he had severe neurologic injury due to both the head trauma as also, an unknown downtime after the cardiac arrest, so hypoxic injury to the brain, and he was comatose. He really had no purposeful movements and did not respond to stimuli on neurologic examination. He had scans done, so multiple imaging studies showed extensive brain damage, really indicating a grave prognosis for any kind of meaningful recovery. And there was concern that he might progress to death by neurologic criteria or brain death. So the NCCU team that was taking care of him thought that they might need to pursue this, testing for death by neurologic criteria. He had a toxicology screen that was pending. So once that was completed and there was no concern about toxins sort of confusing or confounding this examination, they might pursue that testing. They've been in the NCCU for 48 hours. He, with social work and security help, they were able to identify who he was. His name was Anthony D'Souza, and they were able to contact his family. The team learned that he was a 52-year-old immigrant from India. He was a businessman who traveled extensively. He is widowed. He had 2 adult children, and they served as his surrogate decision. They learned more about the family, that they were fundamentalist Christian. The family advocate and hospital chaplain started having conversations with the children, recognizing that certainly if the patient was neurologically quite ill, and that might progress to more end-of-life kind of discussions, really trying to explore with them what the next steps might be. It was explained that more than likely, based on how they've seen him over the 48 hours in the NCCU, it's unlikely that he would have any kind of improvement in his neurologic status. So learning that, the children called other family members, that included the patient's brother and sister-in-law from out of state, and they were all going to be coming to Baltimore to see the patient. The children said, while we're having these conversations, we want to wait on making any other kind of decisions until the rest of the family arrives. So then the patient's neurologic status progressed. He lost all brainstem reflexes. He was normothermic. His body temperature was now normal, and the toxicology screen came back negative. No concerns about toxin in the system. So the clinical team approached the children saying that, he looks like he meets the criteria for death by neurologic criteria. We're going to want to pursue that testing. The children say we do not want to have that testing done. Our religious and cultural beliefs adhere only to cardiac death, death by circulatory arrest. And really, added to that, we feel that as long as he's on supportive measures like the mechanical ventilator, there's really a chance that a miracle could happen, that he could wake up and get better. So they were really declining for having the testing done or doing any other end of life decision. So that's the situation. Let's see from our panelists how they would approach.
So as a chaplain and family advocate, there were a couple of things that stood out to me on this case. First, the thing that I would want to highlight is the fact that I think that it's important to acknowledge that the general public has, for the most part, a really poor understanding of brain death, what it is, how it differs from being comatose or other forms of neurological impairment. And I think that you may see some of that in this case. The second thing that stood out to me is the obvious, religious, cultural factors that go into this case and how that has affected the care. So in regards to both of these things, I think the critical building block when you start to approach this is communication. And so when I think about communication in a situation like this, there are a couple of things that really come into focus. The first is that communication needs to be frequent. It needs to be done on a regular basis between the medical staff, the medical team, and the family. I also think that it needs to be repeated. Oftentimes, things that are communicated need to be said over and over. Families in stressful situations sometimes don't really, they can hear, but they don't listen. And so sometimes they need to be told something more than once for it to really sink in. And so those are two critical things. I think another thing that's important is just to be really precise with the terminology that's being used, especially when you're talking about death by neurologic criteria. Because that can really sow a lot of confusion if there's not consistency with the terminology that's used in that area. And then the last thing, which is really important, and I think is not emphasized enough, is that we need to be good listeners. And we need to be sensitive to what the family's feelings and concerns are in these situations. So it's more than just answering their questions. It goes with that. It's listening to what's behind those questions and where the family's coming from. So when you think about all that together, all that communication piece, there are two objectives there. The first is that you want to cultivate a mutual understanding so that the family understands what the providers are saying, but also so the providers understand where the family sits with everything. And then the other side of that is to make sure that there's a level of trust between the family and the medical providers. And that level of trust is really critical when you're talking about making life decisions. Sometimes that trust and that understanding is pretty easy to do. Other times it can be really difficult because of language barriers, because of cultural, religious barriers. Those are the sorts of things that can really impede some of that understanding and trust between the medical team and the family. So as a family advocate, in my role, part of what I do is I try to help bridge those gaps. Help to try to facilitate communication, understanding, and trust wherever it's possible, while also providing emotional and spiritual support for the patient and for the families.
So I'm going to echo what James said, just about the clear and concise ongoing communication with the families. You have to put yourself in their shoes. I know it's like empathy 101, what we learn in school, but it's really easy to get caught up in your day-to-day to-do list. And but so to be able to just be there with the family and see it from their perspective, they're just learning really shocking news. They're probably, like James says, not hearing you. So making sure the communication is clear and ongoing. Also, as you rotate off service, giving a warm hand off to your team. Hey, this is the work we've been doing with this family. Make sure that when you're in the room, you're present and things like that. The good thing about my role is I'm almost sometimes seen as like a neutral. I'm part of the team, but I'm not there to do testing. I'm not there to diagnose anything. I'm not there to give bad news. I just can be there with the family and create space for them to process the information that they're getting, process the diagnosis, express emotions about it, recall memories, share pictures, things like that. And I think that builds a lot of trust and builds rapport. And not every family is gonna see me in that role, and they're always gonna have a lot of mistrust from the team, and that's okay. Sometimes giving them space and not, you know, making them sit down and process it with you, is, if that's what they need, that's something that we can assess and figure out what's best. And also in that process, as you build rapport and build trust with them and learn about the patient's life, you can kind of humanize them and learn more about their values, their culture, the family dynamics, which can then provide like a context and a framework for why we're seeing families react the way they are to diagnoses, or why they may be opposed to a brain death test and things like that. It can provide us more context instead of just, this is a difficult family, which we hear everyone says a lot behind the scenes. So that's one way I feel like social work can provide some sort of context and really bring that to the multidisciplinary team. Here's why we're seeing this family react this way. Let's, you know, put that into the context of our plan moving forward and the communication we have with them.
I think, I agree with you on this topic. It caused a lack of clarity and understanding, but I feel that also applies to our understanding. I wonder here in this case, like what I would be doing is where in this process do families have the right to decline a diagnostic test? And then where do we go from there? Would be a big question I have. Subsequently, I'm thinking of what is the accessibility and equity of this right to all of our patients, and something that's offered or something that's done more.
I fully agree with a lot of what's been said already. You know, to put it into context, if you haven't actually seen one of these patients before, you know, they're in the ICU. They have a monitor up there that's showing that there's a heartbeat, right? There's a EKG telemetry strip that's showing the rhythm of the heart. You have the blood pressure on the screen. The ventilator is pushing air in and out of this person, and you're seeing the chest rise and fall, right, as a result of the ventilation. It's not intuitive to understand that this body in front of you could be dead while all of that is happening. Even culturally, the way we look at something like this, the way we talk about it, you know, say about doing things from the heart, or, you know, the heart is where emotions lie, etc. I'm a neurologist, obviously, on of the mindset that the brain is doing all of it. But it's very common to understand that a lot of people connect life or death with the heart, right? That's what we're all taught. That's what our, you know, social interactions or sort of speech elements that the heart is important. So the understanding that when we're saying that someone is dead because their brain is dead is not an intuitive concept. If anything, it's something that's the result of modern medicine. Right? In the past, if you truly had this extensive brain damage, and you wouldn't be breathing yourself if your brain dead, and you would pass away, in other words, your heart would stop beating because of oxygenation. Brain death is a concept that exists because of the ventilator in many ways, because we can provide oxygenation, remove carbon dioxide by pushing air in and out. There is an opportunity for the body's organs to persist, even though the brain is completely damaged. So it was only in the 1960s, late 1950s, 1960s, that it was even recognized as a condition as a result of mechanical ventilation. And so it's not an intuitive concept. So I think a lot of what we're talking about on the panel about communication, the reason that's so important, technically speaking, is because perhaps this ethical conflict may actually be an asymmetry of information. They don't know what we know. And to be able to communicate that in a way that's understood is always the first step. And so I fully agree with what's been said by Amy and James about the communication aspect. But you brought up an excellent point also about, you know, who's making decisions, what right do people have to make decisions. And so as a physician, you're thinking, and a clinician in general, any member of the clinical team, you're trying to, you know, stick by some basic ethical principles. You're trying to limit harm to your patient. You're trying to create benefit, right? You're trying to be just and equitable across all your patients. So, a lot of people say, well, what's the harm if the person is dead, right? You can't actually cause more harm by continuing on with what you're doing. You can't actually cause more harm to a dead body, right? Some people may argue that way. Some people may say, well, without the testing, we don't know if the person's dead, right? So there is some degree of trying to respect autonomy, and then the person is not able to speak. And so family is their voice. So navigating this is extremely complicated, and so that's why I think we're going to have a great discussion.
Maybe we can turn to specifically that question of informed consent for testing for, death by neurological criteria. Is it something that you approach the family and say, can we get your permission to do the testing? Or is it something that the team would approach them and say, we have this suspicion, we have to do this? How would you, when the family says, we don't want you to do the testing or we want you to delay the testing, how would you all respond to that?
It's a strange situation. If we thought that somebody was pulseless and had certain death by circulatory criteria, right, their heart had completely stopped irreversibly, you don't really ask for permission to do the test and feel the pulse or whatever it is to know if they're dead. So it's not really a diagnostic test so much as prognostic test, right? Are they alive or not? That being said, if you just go in and just brute force, authoritarian style, just say, this is it, we're just doing it, no discussion, I think you have the potential to cause a lot of harm to the family and the patient's advocates, right? And it's such a sensitive situation. So it's not more about asking for permission, but it's more about explaining and understanding and hopefully coming to them understanding why you're going to do what you're going to do. So it's not emergently time sensitive in the sense that you have to do it right that minute. But I think having the discussion and understanding their point of view and walking them through this is, I really don't think it's a decision that ultimately lies.
Another aspect of that to consider is, if you're talking about death by cardiac criteria, you're checking the pulse, that's almost instantaneous. You can find that out within a couple of minutes. But if you're looking at brain death testing, that's a process that is complicated. The family may not be familiar with what it is or how it proceeds. And, here at Hopkins, we have a policy where there has to be a minimum of 6 hours between the first and second brain death test. And then there's also an apnea test or an ancillary exam. So all this stuff comes into play. That's all part of the brain death testing. But if the families don't have really an understanding of what that means or what's actually going on, I think that could be a little bit disturbing for the family as well.
One thing we consider a lot is just when you think about things with mistrust, we sometimes will invite them to actually watch the exam. So it's not just the team's going in and doing it in the closed doors behind the family's back, and especially for someone with mistrust, here is the exam that we do, explain it ahead of time, invite them to even watch it, so they know it is a tested and something that has been researched, and there's science behind it, and so inviting them to do that, but also if there's any sort of wiggle room for accommodations. Hey, this patient has someone who's been like a mother to them, who's flying in 6 hours. Can we delay that? We really love her to be work all the time of death and things like that. I think that we try to accommodate it, of course, to a certain extent, so that there is again that trust and compassion from the team.
I think this one seems particularly tricky to me because I feel like I can't help but go to then what are we going to and allow with these results. So if we're not going to allow them to find this institution, are we going to allow them to make a choice once you have it? I guess it feels like a slippery slope. That where I see this how people want to stop the data because once they're brain dead, they would be completely dead. But there are certain examples of states that allow people to persist with neurologic that, but not really. So I wonder like where in this is the issue of the sort of decision to stop or ask for institution. Yeah, that's it.
Maybe we can just get clear on the definition and what's required for that. There are these practice guidelines that were published last year, and basically saying that, you know, the old terminology brain death, which then might lead to this dichotomy, well, the brain might be dead, but maybe the body's alive, and that trying to get the education and understanding on the family of actually what that means, that it is equal to death, and you know, states that recognize that. And so this practice guideline is saying that that is equivalent to death by cardiac criteria. And it goes back to the Uniform Determination of Death Act all the way back from 1980. So as Rohan was saying, that, you know, because we have this technology that can support the breathing, the ventilation function, get this cardiorespiratory support, that is going to keep the body going, even if there has been this cessation of all other vital functions. So this concern about, you know, when do you actually determine that there's been death by these neurologic criteria? So the actual definition, I'll turn it over to you, Rohan, since you're the neurointensivist.
Yeah, sure. Sure. So, you know, like I said, it was first recognized in the 60s, just like he was pointing out, it was codified into law in the 1980s, right? And so we're looking at the Uniform Determination of Death Act of 1980. The definition here is above, which is an individual who sustained irreversible cessation of circulatory and respiratory functions. That's death by cardiac criteria or circulatory criteria, or irreversible cessation of the functions of the entire brain, including the brainstem. So I think the reason this definition came to be is because initially people were realizing that we had this whole subset of patients on mechanical ventilation, cardiac functions preserved, who would never ever recover from their state, never recover any consciousness nor any brainstem. And so that's where this definition actually came from, and it's codified. Now we understandably have a very American perspective on this. This is an American law, not an international law. And there are still other countries that don't have a definition of death by neurological criteria. But this comes from the recognition in the medical community that the brain is essentially the center of who you are, right? It's where your memories are, your purposefulness comes from your brain, your emotions come from your brain, regulation of your body comes from your brain. So the understanding that when you have irreversible complete damage to the brain, that is essentially the person themselves dying. That's where this law comes from, and that's where the medical regulation comes from.
And then, you know, more recently, I guess, it's been clarified about what does, you know, all functions of the brain, the entire brain needs. So maybe you can speak to that. How does that tie into the testing that then gets done?
Brain, you know, I'm obviously again, I'm biased. I think the brain is beautiful because it's so complex. Right? There's so many functions. So on a practical basis, how does one say that every single function of the brain is gone? Right? What kind of testing do you actually need to be able to say that? This is from 2023, based on the revised guidelines. We're essentially meant to clarify some of this to make it easier and more understandable to the community so that there is no misinterpretation. But the idea is that permanent, all function of the entire brain is interpreted as a permanent loss of function of the brain as a whole, including the brainstem, and that results in this clinical set, right? So someone who has no signs of consciousness whatsoever, that includes no eye opening, no tracking, any of that as well. No brainstem reflexes. So if you shine a light, their eyes, pupils don't constrict. They don't have a cough, they can't breathe on their own, trigger a breath on the ventilator on their own. And then finally, If you completely remove any ventilatory support and you wait for their body's natural triggers to kick in, they do not take a breath, right? So all of these three are essentially how we're defining all functions of the entire brain in a functional way.
Can other panelists speak to, like, when you're having these family conferences or meetings with families to explain this? There's the medical side of, you know, how the physicians might explain it, but how do you all integrate that information into your conversation with the patient? Or not the patient, Ben?
I think one thing I look for in these meetings is the body language of the family. Sometimes you can tell if they're not understanding something. Sometimes I'll jump in and say, can you tell me more about this? You know, for example, I had a fellow talking to a patient's family one time and said, we have no exam. And the family was kind of like, okay, but you could tell, what does that mean? Can you explain what an exam even is? So I think, you know, being able to watch the family in that moment and just, you know, help to, yeah, help facilitate the communication to make sure that they fully understand, and so that they are able to then provide informed consent for things and are able to understand the diagnosis fully.
One thing I found helpful sometimes in these situations is sometimes families are so overwhelmed in these family meetings that they may not speak up, or they may not ask the right questions, or you know, it's hard to really read them. So one thing that I have found helpful sometimes is just kind of wait till after the meeting's over, and I'll sit there with them. I say, what was your understanding of what was just said? And just see what they say. And you know, an open-ended question, let's see what you actually understood from this meeting. And a lot can be really gleaned from that. And then I can go and help, you know, communicate that to the medical team. And then we can go from there. Sometimes that means that we have to have another family meeting. Sometimes they got it all. Sometimes they understand it. But I think just changing the environment a bit, or you know, again, it gets back to the sort of that trust, the building that trust. And sometimes it's easier to do that one-on-one than it is in a large group.
I would say the biggest, once people have gotten over that sort of initial shock, if they're trying to understand what you're saying, the biggest source of conflict, or not conflict, or disagreement sometimes, is how can you possibly know it's irreversible, right? So you're saying that, okay, the whole brain isn't working right now based on your tests. How do you know something will come back, right? Or like in this case in particular, they say, you know, there's a chance of a miracle occurring. How are you supposed to talk to somebody who says, well, my one loved one is the exception, right? And if you don't let the miracle happen, then you're not giving them a chance. So it might make sense to also maybe talk a little bit about how do we know that this is true, right? So essentially, to date, not one single person ever has met these criteria, has ever regained any kind of consciousness. There is not one exception, right? And there have been cases across the world where, you know, they don't withdraw or they don't that's the wrong word again. They don't remove all the artificial support mechanisms like ventilation or hemodynamic support, things that are sustaining the body. And not a single individual ever regained consciousness. And we're talking about hundreds of thousands, if not more, patients. So that's the kind of the scientific background that we're coming off of. And that's what forms the basis of these definitions of this possible. But it's very hard to argue against a miracle argument.
The only thing I would add is sort of, you've heard people doing here, like precision in your language, bring that big depth, you know, withdrawing support, removal of, you know, technological machines that support. And then I think that's the other thing that we employ in any end of life situation, sort of what is meaningful for this person, what would be recovery.
One other thing to add in the communication in the meetings, so I think a lot of families, they confuse coma, persistent vegetative state, brain death. And so and being able to distinguish those, because we hear a lot of people say, well, I know that this happened to someone and they were able to wake up. And so in reality, that person was probably comatose or in a some vegetative state and probably not brain dead. And so being able to make sure those are clearly outlined in the differences between those as a part of that education.
Can you just speak to that, the differences between those three, death and neurological criteria, comatose, but it might be permanent or reversible, and persistent vegetative state?
Yeah, sure. So when we're saying someone is brain dead or dead by neurological criteria, we're essentially saying this is absolutely irreversible. There's no part of the brain that comes back. Patients can be in comas, which means an absence of consciousness for a variety of reasons. They could be intoxicated. It could be as a consequence of brain injury. But what coma says is that there are still some brainstem reflexes or some other signs that this person has some brain function that's intact. So the difference between coma and death by neurological criteria is in coma, you do have at least one brainstem reflex of some sort. Patients in comas can recover, right? So but the extent of recovery can really vary. So sometimes people are in persistent comas. Sometimes people start having some minimal eye opening, which is, if that's all that you get, we call that the old term was the persistent vegetative state. If they start doing a little bit more than that, around a little more, maybe not necessarily purposefully, we call that minimally conscious state. So there's all sorts of levels of different kinds of consciousness. But death by neurological criteria is actually different. We're saying there's absolutely no brain function, and we believe it's irreversible. So that's kind of the big distinction there.
Let me circle back to sort of the religious aspects of this. So one, there's the miracle that they're hoping for. And then the second was they expressed that they are fundamentalist Christian, and perhaps that their religious tradition or how their perspective on it doesn't accept death by neurological criteria. They only agree with death when it's the heart and the breathing and stuff. How would you approach it?
I think it's important not to make assumptions in a case like this. We never want to assume what a particular family's beliefs are based upon a larger category like fundamentalist Christian. We never want to make assumptions about even if it's whether it's a religious, cultural objection or whether it has more to do with trust. We never want to assume anything along those lines. We want to go in with an open book and as a chaplain, as a family advocate, I'm going to go in there and just start talking to them, and try to build up that level of trust and let them know if they do have a particular religious background and if there's something that I can relate to them on that framework, then I'm going to relate to them in that framework. I'm going to talk to them on those terms as a chaplain. There are other people who are atheists who may have objections to this. So in those cases, I'm not going to come from a religious aspect. I'm going to come more from an emotional aspect, being able to approach them in that way. But whatever the case, it's important to kind of suss this out and figure out exactly what's going on. Is it a mistrust issue? Is it something that has to do with them waiting on a miracle, which is often the case? Is it where they maybe don't understand what brain death actually is? Or is it an objection that's much more fundamental to their actual religious values or their cultural practice? And that's a whole spectrum of things there, and there are different ways that we can relate to those things. If it's something that's really fundamental, sometimes what we'll do is we'll bring in an outside clergy or religious leader to communicate with that family and to help to walk with them through this, so that they have someone who's on their side, almost an advocate who understands where they're coming from, someone that they trust from a religious aspect, who we could talk to as a medical team. We could talk to that religious leader and explain things and see what's really going on. What does their religion actually believe on this? And sometimes that can be helpful. So I think it's important, just getting back to the beginning of this, not to make any assumptions. Every single family has individual beliefs, And you can't just pigeonhole people and make assumptions about anything.
Let me turn it over to the audience and see if there are questions at this point.
I had a
Or
question.
wait, just wait for the microphone. Sorry.
Oh, sorry. I had a question about something that came up earlier. You said the states have differences. So for lay people or even myself, that can be very confusing, right? If there's a medical recommendation, we'll all have a medical board and national levels. So that, how does that come into play? When there's no consensus, like, I guess, in the country or where you can get here, how do you see that affecting people's decisions? Well, yeah.
Yeah, you're absolutely right. So, it's getting confusing. There's federal consensus, right? We have a federal law, the Informed Death Discrimination Act. There's national guidance from, and you can see that practice guideline is not just like one medical society, but across the board, different societies, for both adults and pediatrics. And there's consensus, I think, in almost every state. The one state where there's a little bit of a difference, and I'm not 100% familiar with legal aspects of this. I think that I'm aware of is New Jersey, where they sometimes allow for certain facilities to keep people in those states in a prolonged way. That is because, again, state lawmakers have passed a law that is, I think, in conflict with the Uniform Death Discrimination Act, but it's a legal conflict. And I think it was on advocacy of people in the city Jewish community that law was passed. But again, you leave the United States, right? There are other countries that have been to, I've seen where I've done some medical rotations where you see that, hey, that doesn't exist, right? You cannot declare death by neurological criteria. And so there is variability. And that's what I think leads sometimes to all this conflict. That being said, actually, many countries where you might assume that there isn't this kind of law or understanding, there actually are, and there are countries that are theological in nature, with like strong theological underpinnings in their government that actually do recognize it. So, just like you were saying, don't take the label. Labels are harmful. Really getting. I think mine was a bit of a non-answer, but the truth is it's just about right when you have those kinds of exceptions.
I think the other point is that you would follow the standard of care that is within your state. So if the patient is here in Maryland and we adhere to Uniform Determination of Death Act, that we would pursue prognostic testing with the appropriate communication and working at.
How are you guys? Thanks for having me today. It's so important. I was the program coordinator for working tissue donation for 10 years. And the one thing I will say, everything you're saying about communication is so key. And I think until we as a hospital recognize that we have to practice this prior to being in these situations, there are always going to be a lot of confusion. We have one of those beautiful sim labs here that you can possibly in that $50 million sim lab. We have standardized patients. For 10 years, we had a great program with fellows where they were required to go through end of life. We had living legacy here, and finished legacy. And really, it's so subjective on how each attending handles these situations that when communication falls apart at the attending level, and it's not consistent, then we see that trickle down. This is really an attending-driven process. And if we have somebody like this in a case, then we're golden. But we really need to get in the STEM lab and practice these situations over and over again, and these difficult situations and language, especially. All of you are saying everything is so key. Is so important, but I really hope that we can get back to being in the STEM lab, being consistent, because if we're huddling prior to every family meeting, we're huddling after every family meeting, we're debriefing, we're rehuddling when family dynamics change, because if we're not communicating all along the way, then things seem to fall apart during these situations, especially during something like this. this intense. So I think if we can all get back to, now the COVID's over, and we can get in the sim lab and be in front of those standardized patients and practices, I think these cases won't be as surprising, especially the newer nurses, residents, and fellows.
Thank you so much. This was really great. And it sounds like sort of the answer that I'm going to ask you is that all of you try to straddle these things, it sounds like. But I'm curious, just as sort of a thought experiment, like, where do you find that you ground your decision making for these sorts of choices? Like, do you find that your, for lack of a better word, your allegiance is with the patient or with the family or within standards of practice? Like, sort of where are you starting from to then make your downstream decisions?
Great question. I would say as a profession, right? One of the things that we're always at risk of is introducing a lot of bias, treating one patient differently for the other. So having guidelines that come from above to help kind of navigate some of these ethical complexities and these decisions is very helpful. Our ultimate duty is to our patient, right? And it is to making sure that we do what we can to benefit our patient best we can. This is a tricky situation because your suspicion is starting off that this patient is no longer there, that they're dead, right? And you're just trying to confirm it, which is very different from saying like, oh, I'm trying to figure out if there's a decision to be made about whether to pursue something or not. So I want to reiterate what I said initially is that really, at least here in Maryland, we don't really have a choice. We are supposed to pursue the testing, but you want to minimize harms to family, friends, the people, the patient's loved ones. And I think that's where all that communication aspect really comes in, because I'm trying to minimize the psychological, emotional, impact that this is going to have. The last thing I want is somebody leaving here being like, oh, they killed my, loved one and psychologically scarred. So my principle is still trying to minimize any harm or damage to my patient and try to help them. But this is a strange situation. But really, I'm trying to figure out their and so I'm also trying to navigate all of this communication and amongst the harm.
Doctor.
You said,
Oh, sorry. So one thing that I would maybe add is just something to consider as well, beyond the communication aspect, is our use of time in the hospital. And sometimes families just need a little extra time to be able to understand what's going on, to be able to come to decisions, to be able to accept that their loved one is gone. And so I know that there can be some flexibility. And I know a lot of that is at the discretion of the medical team. And I wonder if you could just speak to that a little bit as well.
The flexibility really comes in timing. I think if I'm looking at it from an ethical perspective, if waiting a few hours for someone's loved one to be there to declare that is something doable, and I don't think it's going to cause any harm. Whether I declare this person now in a few hours, I would think that. But it is very subjective, right? And there's other considerations at play. We're talking about principles of justice and being fair to everybody. We're talking about a very limited resource, right? ICU beds are hard to come by, require a lot of resources. You're talking about a ventilator. You're talking about all these things. And oftentimes we have the privilege of, having one meeting sometimes, but that's actually very often we're in an ICU where, we're turning people away that want to transfer to other hospitals because we don't have beds, or there's somebody waiting in the emergency room who desperately needs a bed. And, but still at that time, that's when conflicts come into play, right? If the same physician is trying to make those decisions while you're here, how do you do that? You justify delaying to not. And so it gets very, very tricky. And there, I don't think that there's an absolute right answer in those situations. Many people try to do the best.
One thing that what I think is so beautiful about the multidisciplinary team in the hospital and in a situation like this is we all are coming at it from different perspectives. You know, the docs are doing what they can medically and communication wise with the family. And they're seeing it from the reducing harm of the patient and also the family. And then from my perspective, the only work I can do in this situation is with the family and reducing harm for them, reducing harm for children in the family. That's another tough situation is when the patient has children involved. We don't have child life on our unit. If there's anyone who can put a plug in, we desperately need child life on our unit. So that's one perspective, one different perspective that I have, that the other members on the team, they don't have the ability to even think about the children in that situation. They're thinking about their expertise. So that's one thing I really enjoy about being on a multidisciplinary team is I do have the time to be able to focus on just that patient. I can set aside an assessment on a walkie-talkie patient that's going to go home tomorrow to focus solely on this difficult situation and reducing harm for the spouses of the children.
I agree with much of what everyone's saying. I think the only other thing I would add would be that I also consider that shared obligation to myself and to the staff. All of those principles of non-maleficence, justice, equity, those are all things that impact all of us as we're making these decisions and having these conversations. And so I think that clarity in the processes, policy, and project really help us figure out when we're deviating from what is standard in order to keep the patient at the center of that.
I think the issue of justice and fairness is also interesting in talking about the difference, for instance, with New Jersey. And so I'm a social worker and work in pediatrics. I'm on the ethics team and happened to be the team lead when a family was stating concern based on religious conviction that their loved one was not present, but as far as they were concerned, would not be declared dead because they didn't believe in their faith did not believe in death by neurologic criteria. And they were able to privately pay for the patient to be transferred to a facility in New Jersey. But that's not something that every family is going to be able to do. And in terms of the coordination of it, finding the facility, being able to pay for it, being able to pay for somebody that's on a ventilator and cardiac support to be taken via very expensive medical transport across state lines. And so, I think that there's the sort of ethical consideration on a national level of where do we put our funds, right? How do we spend a limited amount of money on trying to provide the best care across the board, but recognizing that in addition to that, every family is in their own social and financial situation, and we are not designed socially or in terms of government resources to be a more equitable society compared to some other countries.
I just want to respond or take it as an.
I agree with what you're saying. It's we're in a system where some people just have more resources than others sometimes, and when we have especially this discrepancy between our legal systems, right, and different states, some people can take advantage of it. Doesn't seem necessarily fair if they have this religious objection.
Comment? Yeah.
I think your question is a wonderful one, and we all struggle with that. My question for the panel and for everybody is that is justice can be bought? So what is ethical, legal, moral permissibility? I'm a chaplain. I'm absolutely sensitive for any faith, whether they have faith or they don't have faith. We uphold their values and beliefs. But on the other side, what we struggle is that what is the legal prerogative for a provider? If you are in a state where the law kind of gives you the authority to declare this patient, if the declaration comes, insurance does not pay. So by not doing that, are we spending all the taxpayer money towards somebody? I mean, these are all the great questions. So we definitely value their values and beliefs, and we've got to be sensitive. And at the same time, we have international patients who come here. Their availability is almost like $500,000, and it only buys twice a week, wants to come and wants to go, and they want to pay and take their loved ones. So if we do that, we need to be kind of like be sensitive to the issues of equity, and that is something that the institution needs to think through.
Well, also still adhering to the legal mandates of when a person's dead, you have to determine that. There was a question here. You saw the question?
Yes.
Wait for the mic.
Thank you.
Thank you, Laura.
This is extraordinarily informative. Doctor, you use the word belief. We believe there is, and paraphrasing, there's no brain function. Do you always use that word, or are you more definitive? And do you use that word out of a sense of gentleness?
Great question. I didn't even catch myself using the word. So I would say that if I'm counseling a family, I don't use that word because it opens up the interpretation to your belief is different than our belief. So in the family meeting where we convinced, we say the evidence is clear that this person is dead by neurological criteria, or there's a strong suspicion that is the case, and we need to confirm that with our testimony. But we don't say at the end, oh, we believe this person is dead. We say this person is dead.
Yeah, I took it that you were meaning those 48 hours where you haven't done the testing yet, that you suspect, you have a suspicion that the person is dead, but you haven't confirmed it with the testing. So this conversation did unfold with this family, and ultimately the children. Well, let me, before I go to that, do you want to comment on this one? Just how we think about the implications of death by neurological criteria. Right?
Yeah, just to re-emphasize, I think the audience is probably not this picture, but when we say that by neurological criteria, we mean death. I know you emphasize that. And so you could actually have these very strange situations in modern medicine. I just wanted to point it out that somebody could be pulseless, right? On an ECMO machine, where the machine is performing your circulatory functions, and you're still alive. You can be walking around on an ECMO machine. Or you can be dead to be part of what we're talking about, right? Which is death by neurological criteria, just manifestations.
So there was a question of what happens next. We missed some slides. The family was approached, the children, and told that the brain death testing would progress. That was performed and confirmed that the patient was dead by neurologic criteria. At that point, organ procurement organization become involved to discuss the possibility of organ donation now that the patient is deceased. So they consented to organ donation, and while waiting for the operating room time to open up, the body is being maintained on supportive measures, including the mechanical ventilation. In that time frame, the patient's brother and sister-in-law arrived, and they disagreed with organ donation. They pushed for the children to insist that the patient be kept on these supportive measures. And the brother again, speaks to his religious beliefs that if you pray hard enough, a miracle will occur and the patient will wake up. So here we've had a situation where death has been declared, a death certificate has been completed, there's been a pursuit of organ donation, and now family is objecting to going through with the organ donation. Let's see how the panelists would handle this part of the.
I think it is important to, from a strictly sort of objective or legal standpoint, to recognize that the patient is dead by law, and to recognize that consent was already given, presumably by the medical decision maker, that organ donation would go ahead. Having said that, we have to, as providers, we don't want to leave, we don't want this family to leave the hospital again and say, you killed my loved one. We need to be sensitive. And so there's an opportunity there to have a meeting with a family, with these new family members that have come in, and to answer any questions about brain death, maybe explain that again, to answer questions about organ donation, what that process is, and really sort of address any fears that they might have. But also, let them know again that your loved one is gone. I mean, as hard as that is to hear, and there's no chance of them coming back. It's never happened. And at this point, because death has already been declared, the organ procurement organization can be involved in this meeting. They're excellent at educating families about organ donation and how that works. A family advocate can be in this meeting, social work, nurses, doctors, whoever want to be involved to be able to help to express these things to the family. And just to be compassionate, and hopefully they will make a decision to proceed with organ donation. We all hope for that, because that can save someone else's life. But ultimately, the family has the right to change their mind, and in that case, we would have to take them off mechanical support.
So if you give consent once, that is.
I think that the person who has the right to give consent has the right to withdraw that consent. So, in this case, there would be one person in that room. And if somebody knows that better, John or one of you knows that better, then please answer that question.
That is correct. So if someone gives consent all the way up until 5 minutes before they OR, they can rescind. It does become a difficult situation because the organs have been allocated, recipients are waiting. So it is very difficult. All the resources, the time. It's a very difficult situation. It doesn't happen very often. If the donor is designated, of course, that's a different situation. Then we go get done. When we have that families who send consent all the way up where they are. It's not often, but it's not.
And in Maryland, what's the legal hierarchy of like self-declaring yourself as a donor versus a surrogate? What's the legal hierarchy of self-consent of being an organ donor license versus a surrogate consenting?
So if you are designated on the license or through the website, then that's a legal binding. After it actually exists in wills, estates, and trusts, where you will a house to another human being, it exists in that area. So you're willing to get to another human being, and that's where it exists in the law. So if you are designated, then that is fine.
So it would be considered, first person consent if the patient previously designated themselves as an organ donor. We have to respect that decision by the patient when they were alive and made that decision. The family can't come along and say now we remove that consent because it was from the patient. They would have to give compelling evidence that they've had a conversation or some written documentation by the patient that they rescinded their organ donation. Without that compelling evidence, then the team is obliged to follow what the patient had said about being.
I know we're getting close to the end of our time, but I think there's one other thing that we're discussing that we haven't been asked and hasn't come up, and that is how the actual, how a family is approached about organ donation and how that proceeds. And so what will happen is, that there's what's called a decoupling. So that, death has to have been declared. And in the case of death by neurologic criteria, the time of death is typically at the second pre-death exam. And once that time of death has been declared, the family has to understand that has happened, right? They have to recognize that they have been delivered that information. And oftentimes, give them a few minutes to digest that, or a couple hours, whatever it takes. But then at some point, typically no more than a few hours, then the organ procurement organization representative can go in. And they will be introduced typically by the medical team or by the family advocate. Will come in there and say, we have someone here who would like to talk to you about next steps. And that's sort of the terminology that seems to work. And whenever the family advocate or not family advocate, but the organ procurement representative comes into the room, they do. I mean, they'll establish a rapport with the family. They'll give them information about funeral homes. They'll give them information about counseling support. So they're not just jumping straight into, this is why I'm here. We want you to donate an organ. But they do get to that eventually, and they give the families that option. And it's done in a very respectful way. And for a lot of families, I think it's important to understand that for a lot of families, it really helps them with the grieving process. If their loved one is able to be an organ donor, it provides them with a way where their loved one can continue to bless someone else and can save some other lives. And so even the name of our organ procurement organization here in Maryland and DC and Virginia, Infinite Legacy, it's leaving a legacy. And so I think it's really important to recognize that can be a really important part of the grieving process for families and really helps them to have some closure oftentimes.
That is absolutely correct. This June, I'm going to celebrate 30 years after my liver transplant. So I had a transplant here at Johns Hopkins 30 years ago. I'm good friends with my family. And educating people and having sessions like this is so incredibly important. The most donors we've ever had in an entire year at Johns Hopkins is 24. And typically we have 15 to 20 organ donors here. So it almost never happens. So it's so incredibly important that every single case is done well and that we're very consistent in how we care for these families. Because any type of inconsistency, whether we miss a referral, the attending doesn't huddle, anything that's missed, ultimately, of course, the family getting great care may be compromised, but ultimately, so the recipients may be compromised as well. So again, really getting together in the sim lab and doing this ahead of time is so important. So we're not, it doesn't seem so unusual during the situation. So many people go into this and have so many questions, but there's so many opportunities to practice that I don't think we can do that. Thank you for having me.
I just want to add one thing to what James has said, with your permission. The thing is, whenever we do the approach for organ donation, that is the place for the distress for the family, so the family can perceive that this is all orchestrated for the sake of organs. I think establishing a clean boundary between the care providers and the team and making the distinguishing mark between the family's perceptions and the team's boundaries and making it a collaborative approach and having their faith leader, their spokesperson out there. And then also saying that this is kind of like options that are offered across the board for everybody. And that language is more crucial in gaining families' trust.
Well, but
great and so needed. Thank you, and to all of you. I just wanted to step back. I've been thinking a lot about the miracle language and across my career. I've been interested in just the thought of that has been published on how to address the miracle. And I think, or this idea that someone wants a miracle to occur. And I think that there are, it's important to address it. It's not unusual, it's kind of normal to think, to hope that things would be different, or, but I do think it can be almost a roadblock sometimes. Some people are more verbal about it than others. And I think kind of addressing it that if the miracle can happen, we're not disallowing it to happen, but we're just making sure that we're not kind of judging them based on the miracle. It can very easily be the thing that can cause a loggerhead. But I think addressing that, I'm sure that's something that we would all wish would happen, but it could happen, you know, despite there's probably body language that we're using right now. But I wonder if you have any things or experiences or you addressed it in positive ways, but I think it's important that we address it and don't judge it. Don't tell people it can't happen, although, you know, we have evidence to the contrary that in this case that injuries were possible.
I think you actually said it really well. You know, it's something that we need to acknowledge. We need to come alongside people in that hope. Say, yes, we're hoping for that miracle too. And you know, sometimes that will happen, like you say, and despite everything that they're being told. And you know, whether that happens or not is really in the hands of the God, the creator, the deity, whatever they call that. But you know, it's something where that doesn't mean we can just stop what we're doing either as medical providers. And you know, you have to acknowledge that, you know, God is greater than this. If God is going to do this miracle, he's going to do it, and he'll do it, you know, before it gets to the next stage, or you know, whatever that could be. But it's really hard, and sometimes it does require a little bit more flexibility and time by the team or whatever, within limits. You know, we can't just extend things forever waiting for a miracle. It's not reasonable. And then it comes into these ethical issues of use of the facility and use of resources. So I think all that stuff is legitimate. You know, those concerns are legitimate. The miracle talk is a real thing in hospitals, and it's a difficult thing to deal with. It's something that I have found that a lot of families and a lot of team members are asking these same questions all the time. And there's not just a clear-cut way to deal with it. It's every case is individual.
Do you think normalizing that we all wish things were different?
Absolutely, yeah.
Any other questions? Final comments from all of us?
Well, first off, thank you all for being such a fantastic audience, being engaged. I'll say this, and this is one of the most difficult conversations that a medical team has with the patient and families. And it really skirts the lines of so many ethical issues, right? Like, does a potentially dead body, to what extent do they have autonomy? To what extent is this a decision versus something you're just doing? To what extent are we just across the board? You know, to John's point that he brought up earlier, you know, even if you look at government institutions, you know, different policies value human life differently. Like the Department of Transportation's policies with safety and how much they spend are very different from what Health and Human Services spends or what the Department of Agriculture spends to save a human life, because that's not the primary metric. So there's inconsistency, there's inequalities. It's a very difficult situation to navigate. But I think what this panel, I think this awesome panel has emphasized is we're really making sure that we're communicating and minimizing harm to family members, explaining decisions in science, not being judgmental, like that's, you know, when people are making things like that, but what's the most human thing to do? That's the best way we can approach this.
This is an amazing and also interesting hearing from all of you from all different perspectives. I just wanted to mention that there's an event at Saul Levinson, which is John Valley, Saul Levinson, and Bill Press is Saul Levinson is the only Jewish funeral home in the area. And Bill Press being a hospice agency, and the purpose of it is to have a conversation about how Judaism, different different sides of Judaism, how they view death and dying, and I would imagine that for some people who came today, that might be of interest. So I think it's on the Saul Levinson website, probably on the Guildhall website, but it's on March 3rd, a Sunday evening. But it may be interesting for some people who are here.
Thank you all. Thank you, our panelists.